apparently we're live. I'm sure many of you have done this. There is something quite staggeringly disconcerting about sitting in your own kitchen, giving a talk to an audience of unknown numbers, sitting in their own kitchens listening to you. So I hope I will do this justice for you. The advantage is the pre-speakers lounge does at least contain biscuits you like. I'm going to talk about NHSX, innovation, and some of the transformation agenda that we're delivering. I'm going to do that without slides. I can put up slides, but then you just listen to me reading them out, which is not much fun. So I'm going to just talk, but I'm very happy later on to share slides if that would be helpful. I'm very happy to take questions on this, and we'll leave some time for Q&A. Stick them in the chat, and they will get passed across. So NHSX itself, for those who aren't familiar with it, it's a new joint policy and strategy team. It's focused on accelerating the digitization of health and care, and specifically on enabling the transformation that comes with that. So we're not just about the products. We work with our partners in NHS Digital and NHS England on getting the products, but also about how that joins together from multiple arm's length bodies. And we aim to provide consistent and clear policy advice to NHS England and to the Department of Health and Social Care, as well as the other arm's length bodies. I'm going to talk you through our missions, what we're trying to achieve, run you past a couple of concepts that we're looking at the moment, including a national wellness service and joining up care, talk to you a little about coronavirus, the successes we had during a very difficult period of coronavirus, and then specifically look at the innovation work we're doing both now and looking forward. So the NHSX missions, we've got 5 of those. Reducing the burden on clinicians so they have more time to care for patients. Empowering the citizen, by which we mean enabling members of the public to have access to their care records, to interact with their care records. And when we do that, we save burden for the health service, rebooking appointments, repeat prescriptions, and so on. But we actually enable citizens to get better care by having access to diagnostic test results, care plans, and so on and so forth. And that's in all sectors. We aim to improve safety. Digital systems are critical to improving safety, but they also come with an element of risk. And that is particularly true when you start layering them. So when an algorithm produced by one company is layered onto a software system produced by another, reflected in the software system of a third party, you can imagine that compounding adds quite profound elements of risk. And we've seen some of those in some scoring systems and so on. We've got to make sure care is safer. Then we're looking at how to deliver some of the productivity improvements that other industries now take for granted through digital technology. And the NHS is an outlier for not having done this. And during the coronavirus outbreak, we noticed, I think, one hospital bought one fax machine, which caused uproar in parts of Whitehall. I think that's now been dealt with. But the fact we're last to the party on the real value driven by digitization, by ensuring all clinical records are available. That's the next one I'm going to come on to. But that all clinical records are available at all points of care, that we understand our processes, that we have access to real-time business and management information in order to understand our processes. We're not there yet, and we need to be in this 130 billion a year industry that is the NHS. And we need to create a system that enables clinical information to be safely accessed wherever and whenever it's needed. And that's our 5th. So just to go through the first of those concepts I was describing to you earlier, this is the concept of a national wellness service. You could call it predictive prevention. You could call it maximum citizen empowerment. It sort of doesn't matter. And as I say, the aim is not to describe a brilliant new service. The aim is to look at the synergy you achieve by bringing together a number of existing pieces of work. And those would include the concept of health checks. I'm 49, this is now sort of terribly important to me, but we've traditionally looked at 10-year risk scores. So for someone of my age, for others in the audience, your 10-year risk score for giving up smoking, for reducing your body mass index, for reducing your cholesterol or your blood pressure is not terribly exciting, to be honest. If you look at your lifetime risk score, it is. And if you look at your compound lifetime risk score, from all of those modest changes in all of those parameters, it becomes really profound. I mean, we're literally talking about how long do you want to know your grandchildren for territory. That's something that's of some value in a GP surgery or an emergency department or a clinic, but it's of real value if it's owned and understood by an individual and their family. One of the principal ways of getting people to give up smoking is to explain the harm smoking does to their children. So we want to get these concepts out there. Immunizations and vaccinations. This country is very good at first immunizations and vaccinations, but is challenged with ensuring people get second and third doses as appropriate. So those aren't people who have a fundamental objection to vaccination. It's that they're lost to follow up, the system's too clunky, it's challenging for them to get the time. How do we provide complete convenience for people with these sorts of functions? One can envisage a world in which your second vaccination is a QR code on your phone that entitles you to go to any high street pharmacy or any care setting if you're there for another purpose, flash the code and go, oh, yes, of course, we'll sort that out for you. And in doing so, it will update your record wherever that may be. We're not there yet, trust me, we really aren't. The national screening programs, something we're very proud of. All of our national screening programs, particularly for bowel cancer and cervical cancer and for others. But we want to extend those and we want to get much more granular with them. Well, we've got fantastic databases of the citizens as a whole and the illnesses they have in our primary care data. And as you know, all primary care data is digital across the NHS. How do we use that to offer people screening that's really meaningful for them and helps prevent illnesses that might otherwise prematurely end their lives or adversely affect them? We also need in this same service to give access to care plans and records and quality information on what really good looks like for their particular long-term conditions. I've talked previously about transactional interaction, including repeat prescriptions, bookings, and so on. Those need to be in. This service needs to offer a practical utility. And then lastly, advice and guidance. So at the moment, you may have access to your GP record, millions of people do through apps. But if they want advice on whether or not their child's got measles, they might go to NHS UK. Whether they then want advice on whether they need to be seen for that condition, they would go to 111. Well, if we were a commercial company, whether in the travel sector or retail or any other, we would make sure our service looked seamless, even if its component parts were drawn from different directions. So how do we integrate these in their reflection to the citizen? Nor am I suggesting that we, the centre, are the best people to do that. I've seen some fabulous products produced by excellent commercial companies that do this. We should enable an API environment that allows people who want to produce fab products to do so with real value add to the citizen, who can then choose the one that works best for them. The next concept I wanted to describe is one we're calling joining up care, which it sounds a little bit of a no-brainer, but it's got three very specific components to it. Access to records in social care. And one of the things coronavirus taught us, beyond many others, was just how disjointed health and social care were, and we need to bring them together, hence joining up care. So access to the relevant clinical record in social care in a timely manner. Well, that's obvious when it's digital, but it's sometimes 2 weeks or more away when it isn't. So people are being transferred from the acute sector into the care sector, but their records or their change of medications or whatever else may matter follows quite a long time later. We need to improve that. Innovations in social care, digital innovations. And I'll come on to some of these in a moment, but we've got a brilliant team led by Tara Donnelly working on this at the moment. And we've seen some outstanding examples for really quite modest sums of money, doing some fantastic changes. So we're trying to find them. we're giving them funding where appropriate, and then we're really trying to work out how to spread that innovation across the NHS and the care sector. And the last of these is the shared care record. So I talked previously about access to a record. The shared record is saying, what are the components that need to be brought together to make this work? And there are a number. At the very least, one wants medications, care plans, access to letters, and test results. But how do we change the conversation from a passive view of something like a care pathway to that being a truly digital product that effectively reflects its own quality information back to both the patient receiving it and to the clinician providing it in something approaching real time? And I've seen some brilliant innovative examples of that, so that were I a clinician with patients on one of these pathways, I would be alerted when people started to take too long to receive particular aspects of their care, and I could talk to my team about what we needed to change or improve, and I would be fed weekly stats on how I compared to baseline, my peers and others. We clinicians, I'm an A&E consultant when I don't do this, we're a competitive bunch. You give me that sort of information and I'm inevitably going to start improving my care in order to ensure I'm doing better. And that was most brilliantly illustrated, by the way, in Germany. And we're going back over a decade, where they started doing this sort of national reporting, and they gave clinicians a heads up. I can't remember how long it was, 2 or 3 months, something like that, ahead of this data being published. And what they saw was, if you drew a sort of box and whisker plot, one standard deviation, 2 standard deviations, those whiskers shot in. Nobody wanted to be a massive outlier. And then the box narrowed, and then the whole lot rose in terms of quality. So we're interested in innovation and variation of care where that's positive variation. We're not particularly brilliant at measuring that at the moment. We want to discourage and we want to help people understand when there are negative variation in quality of care. And we think that access to shared care records is one of the really key ways we're going to enable that. Next, I wanted to talk about coronavirus and the successes we had with digitization during this exceptionally challenging period. So as you know, this arrived with us in earnest in March. Clearly it's been present earlier, but we essentially stopped routine business, stood up a clinical cell, and worked out relatively quickly, within a week, I think it was 3-4 days, something like that, the most important innovations we could do for the NHS. And we were making some assumptions. And those assumptions were in principle based on looking at Northern Italy and seeing just what an appalling time they'd had. And so we needed to make sure that we could function even if we're having as bad a time as they had. Online assessment tools. How do we move 111 online? And we did. We went from 80% telephone, 20% digital, something like that, to the other way around. Video consultation for secondary care and for primary care, isolation notes for people who needed to self-isolate so they could get recognition for being off work, automated assessment and physiology for 111 patients. We were sending text messages to the symptomatic patients to encourage them to stay at home and to allowing them to notify their symptoms. We enabled general practice, remote working, remote triage tools, video consultation, smart card access, laptops to people's homes. We literally took warehouses of laptops and sort of shipped them out to people. Really interesting workload reduction stuff in the community space, with pharmacy, optometry, dentistry, ambulance services being equipped with the necessary technology to help them be part of the overall coronavirus response. And we're now moving into the era of 111 first, so encouraging people to seek advice and guidance before necessarily going for face-to-face care. How are we doing? I'm going to do about 5 minutes or so on some of the innovation space we're in at the moment, and then, as I say, very happy to take questions for a while. So we've done a whole bunch of stuff on artificial intelligence and natural language processing. We set up the NHS AI lab. Last Tuesday, we announced 42 successful data-driven technologies in this space. our aim is that the NHS really does become a world leader in the use of AI and machine learning. And as you know, it's gone through a slightly trendy period where everybody slaps AI and machine learning into almost any product. And I've certainly learned if they do that too often, it may not be entirely true. But we've seen some brilliant stuff. Healthy IO, turning a smartphone into a clinical grade device to spot albuminuria. iRhythm Technologies for wearable ECG monitoring. Brainomics for emergency stroke patients. These are superb innovations. We've got some world first technology. First time it's been used in the real world. So Chiron Medical for breast cancer scans being read, and they're really accurate. It's extremely impressive stuff. My wife's a radiologist, I have to get this right. Ibex Medical Analytics for detecting cancer from prostate biopsy slides, something dear to my heart with my father, trying to get this right. Where we have restrictions in the amount of human resource we can bring to bear in the NHS, and technology can relieve some of that burden and enable us to do more and better. Echo Duo, a smart stethoscope that records an ECG as well as listening to your heart. That's going to completely put me out of business, but there we are. And the Oxford Heartbeat to understand patients going for high-risk brain surgeries and how to better care for those. In each of these cases, what we're doing is taking something that humans can do, but augmenting it, making them better, freeing up people's time and enabling them to concentrate on the cases where the human is most valuable. That's one section. The next set is supporting people at home. So we're still actively now looking for best practice examples of supporting people in their own homes, so that as we move into a potential second wave of coronavirus over winter, we can enable more patients to be cared for better in their own home and therefore not need to come into acute care. Meaning we can use the beds for others, but also meaning we reduce the infection risk to the hospital setting, and we continue to provide excellent care for the citizen in their own home. And where we can monitor people in their own home and they're sufficiently well to do so, people love it and like it, by the way, because they know where everything is and their privacy and dignity are better maintained. So we're putting in a new procurement system, a dynamic purchasing system. And please, if you've got innovative products in this space, let us know, as we're actively doing that at the moment. We're looking very earnestly at the challenges here, because it isn't all plain sailing, and we want to understand the consequences and challenges. So we're not creating a future technical debt here, or creating unsustainable delivery models that simply can't be matched in the real world NHS. That patients and clinical staff are truly realizing benefits, and that's quite challenging, and that we continue to provide safe and effective care. Last bit, I think, from me, we're mapping the whole of the robotic process automation landscape. It's a really interesting area. We've seen some fabulous best practice. There's a lot going on in the NHS, and you can have people in different parts of the same organization not understanding what each other are doing. Recent blog by Dr. Maddy Barani in NHSX. Do read it if this is your area. But how do we automate all those back-end tasks? Something other industries have done enormously. If there are good practice examples you're aware of, let's have them, please. I'm going to stop there because I could talk all day about this, and the questions are pouring in. I've only got 5 minutes left, so let's take some questions. Karen, thank you very much for posting those up for me. Keep putting them in if you've got others, and I will keep talking until I'm shut off. The NHS is known to be a very difficult organisation to get into for those for digital solutions. Absolutely. Is NHSX now the best arm of the NHS to be connecting with this? What do you advise companies starting? It is, and it shouldn't be. And what we've seen far too often is a company will succeed in their first opening, often through personal connection, through one of their clinical innovators, or some other connection with the organization, and they've demonstrated success in the NHS. But when it comes to making the second sale, as it were, the second site, they're starting again from scratch as if nothing had happened. That's not good enough. So Tara Donnelly and the team in NHSX and Tony Young and the team in NHSE looking at clinical entrepreneurs and others, we are absolutely committed to helping share innovation all the way across the health service. So we are finding brilliant examples and we are then publishing them. We are now working with all of the CEOs in the NHS to make them aware of what good looks like and what they should be aiming to do. So this stuff is not voodoo science and they don't need a brand new business case to prove it all. This is something that's clear, proven technology. To give you an example, I'm having to sell the concept of bleep replacement technology to CEOs. This is old hand stuff that is extremely dull and we just need to get on with it. So do come and talk to us. We have a whole unit dedicated to chatting to you. We're offering a Centre of Commercial Expertise. I think we're giving it an even better title to help the NHS understand how to adopt these, how to get their business cases through and so on. Next one. How are the NHS working, sharing ideas on innovation with the rest of Europe and other global healthcare systems? And will Brexit impact this? Oh God, I'm going to have coffee at that point. I'm not going to talk about Brexit because this is a no swearing talk. But we are working very specifically with partners. We have a number of alliances we work with. There's a specific Northern Futures Forum. I've done a lot of work with the Baltic and Nordic nations who are brilliant in this space. We do work with European partners, including partners in Italy, Germany, and elsewhere. We're also working with a group called the Global Digital Health Partnership, specifically looking at innovation policy challenges and the AI challenges I mentioned. That's about 30 nations. Clearly, coronavirus has interrupted much of that activity just at the moment, but our aim is there is essentially nothing new under the sun. Someone somewhere is doing it, or somebody's got to be first. And the point of each of those networks is to help us share best practice. And they are brilliantly collaborative, by the way. They're really excellent. Should I, as a digital health entrepreneur, be trying to work with individual trusts in the UK? If you are a clinical health entrepreneur, please do talk to Tony Young. There's a piece out there right now looking for best clinical entrepreneurs and how to fund and help them. So yes, do talk to individual trusts, particularly if you've got connections and somebody's interested and wants to take the product, by all means, but do talk to the accelerated access collaboratives as well. Part of their job is to help brilliant digital health entrepreneurs get better traction in the NHS. They're set up for it, they're funded for it, and they will work with you to help that happen. Then I said, it reads, I think that's all we have time for, but actually one more. What are the top 3 digital solutions the NHS needs? Oh, all right. Sticking to the no swearing rule, I hope you're impressed. It's top 3. I don't know I can describe the digital solutions. I can certainly describe the outcomes we're aiming for. I would like the average patient to be as plugged into their clinical record as they are to any other record that matters to them, be that their tax return, their car's service history, I don't know, whatever else that they may need, their own online search history, who knows. But at the moment, your health history is weird, special, and belongs to the health service rather than being yours and being actively useful and usable by you. So that's absolutely fundamental to me. It is to open this up. The second space we've got in here is to enable the best practice of sharing records. So we're moving to an API-based environment here, and what I'm after is brilliance on top of that to make it very easy to navigate and to work your way around. So if this side of the table, as it were an army of clinicians, what they'd tell you is that core products in the NHS, in almost every care setting, are not very good, sticking to the previous rules. They really are surprisingly clunky to use. Even the new innovative whizzy ones that are staggeringly expensive from the US are really challenging at times to make work in the way people want. And yet I can sit my 9-year-old down in front of this, and he can work it in seconds and did all his learning online over the summer. And I can do the same with my 88-year-old father. So where a product directly faces a consumer and its success is dependent on consumer use, the user interface is excellent or the product vanishes. But in health-facing products, we seem to put up with very counterintuitive user interfaces that are extremely busy and cluttered, and we consequently have to take people away from the clinical environment in order to learn how to use the products. And if they change organization, they have to learn it all over again. That's not good enough. And so that's 2. I think I'm nudging over my time, but I'll go. And the third thing I'd say is interoperability. And my example I give par excellence for that is medicines. It seems to me unacceptable that any clinician, when they want to know a patient's medicine, is basically looking at the local copy of that information, not at the core of that information or a guaranteed up-to-date version of that information. And it leads to medication errors, it leads to safety alerts, it leads to patients getting suboptimal treatment and at times getting medications they're allergic to. This is just wrong in the 21st century, and we need fully interoperable medication records, effectively a single source of truth, whether that means constant update or whatever, I don't mind, across the whole of the health service. You help solve that one for me, I should be utterly delighted. I think we've probably run out of time, but thank you so much, and I hope at least both of you listening enjoyed it enormously.